Good afternoon, sir. Dr. Prashant, sir, can you hear me?
Yeah, I can hear you.
Good afternoon, sir. This is Rituparna from Climate Services. We are already moderating the session with you, and we will be starting the session. Start at 3:30 p.m. Right, sir?
Yeah, yeah.
And
There is a lot of background noise coming from your end.
okay, sir. I'm checking it once. Hello. Sir, please check once whether this audio of mine is right proper or not.
It's right, but there is a background voice. I don't know why.
Okay.
Rheumatic
Rituparna, there are participants who are not able to log in. It says 6 minutes to go. Can you just open the room now for everybody?
I have opened the room. Let me check if there is another IT issue or not.
Yeah, yeah.
Right, sir? I
Fine.
have. Oh, yes, sir.
આ એ ભલે આવે છે પણ પેલું
Hello, sir. Dr. Prashant. Can you hear me?
yeah, yeah.
Sir, we have opened the room for all, right, sir?
Fine.
I think that the participants who are unable to join in, they are facing some problem from their side, sir.
The basically issue is while clicking the link, the flyer is not updated. It shows last time's flyer, so people are confusing. I think Dr. Dipen Patel has joined now, so not an issue.
Okay. Let me check, sir. Attention, please. It's a kind request from our side that if any of the participants are using the phone and the laptop for login purpose simultaneously, please check it because we are having some sound echo problem over here. So if anybody is there who is simultaneously accessing or logging this session with of the phone and the personal laptop, please make sure you join with a particular system.
Rituparna, now the echo is not coming, so I think the problem is solved.
Okay, right.
Yeah.
Good afternoon, ma'am. Ma'am, તમે muted છો.
Good afternoon.
Yes, ma'am. મજામાં, ma'am.
બસ બિલકુલ.
And Sachin sir, good afternoon.
Given by Toral,
Toral, Shraddha is there to help her. So I think she may join in 1 minute. Let's see. મેં ટ્રાય કરો પણ ફોન ચાલુ જ આવે છે એટલે શ્રદ્ધાને મેં મોકલી છે તો probably she will help in 1 or 2 minutes.
we welcome Dr. Sachin also.
Yes, Dr. Sachin sir.
Welcome, Sachin sir. You are muted.
Good afternoon, everyone.
Good afternoon.
Good afternoon.
Sir, the presenter is facing some issue to join. So
Yes.
she will be joining in a minute. Just to brief, there will be few participants who will be there on Zoom, few on ClearNet platform and few on YouTube. And while Toral is presenting, both the experts, Sheila ma'am and Sachin sir, both can ask the questions on any slides. We are glad that Dr. Somshekhar has also joined, our advisor. Welcome, Somshekhar sir.
Good afternoon.
Rituparna?
Hi Sachin, hi madam. कैसे हैं?
Hi.
Thank you.
Hi, Samshekar.
Hi, thank you. Sorry,
Yes,
my
sir.
video can't
So
start.
shall we start?
Okay.
Rituparna, just 1 minute. The presenter Toral is having some issue. I am just
She
contacting.
has to join before we
Okay,
Just one
okay,
minute, one
okay.
minute.
Yes, sir.
Thank you all for taking your time out and doing this for us. It's
No, that's
She's just joining in a minute only, Rituparna.
Fine, sir. Just prompt me. Just prompt me when I'm supposed to start. Right, sir?
Yeah, sure.
Okay, sir. Thank you. Not an issue.
Toral has joined. Her audio is joining. So, yeah. So, Rituparna, we can just start. We are. Toral, say hi. Yeah.
So, shall we, sir?
Hello,
Toral. Toral, just say hi.
Okay. Let me start then. Right, sir?
Just 1 minute. Toral.
Good afternoon, everyone.
वीडियो
Yeah,
ऑन
fine.
करो, अपना वीडियो ऑन करो तोरल.
Fine, Toral. Yeah, Rituparna, we can start.
Yes, sir. Good afternoon. Good afternoon and welcome to all the respected personalities present in this session. I am Rituparna from Clarinet. Clarinet is very proud to be a part of this webinar as a digital partner. Now, I would like to present you all a short video of Clarinet. I am Rituparna from Clarinet. Clarinet is very proud to be a part of this webinar as a digital partner. Now, I would like to present you all a short video of Clarinet. Thank you. Thank you all. Thank you all for all your patience. Clarinet is India's one of the live digital CME platforms in India, where doctors can create their own medical content. We have MedWiki services, which is a medical content provided by the doctors only. And we also have our special video contents provided by the doctors from across the globe. I would proudly invite you all to please join our platform. That is, the website is www.clarinet.com. And now, without any further delay, I would like to quickly hand over the session to Dr. Prashant. Over to you, sir. Proceed with your talk.
Thank you so much. On behalf of NNF Gujarat, I, Dr. Prashant Karia, Secretary, NNF Gujarat, welcome one and all. I request our President, Dr. Dipen Patel, to welcome one and all.
Good afternoon, dear colleagues. On behalf of NNF Gujarat, I welcome you all on this digital platform. Our sincere thanks to Dr. Sheila Madam and Dr. Sachin Shah sir for accepting the invitation to be an expert in this weekly program. We also thank Dr. Toral Gandhi and Dr. Resma Pujara for mentoring her in preparing the case. I request Dr. Prashant Karia to introduce our experts and the presenters.
So thank you so much, Dr. Dipen Patel. Dr. Toral Gandhi is a resident in Karamsad Medical College, and she is going to present a case today. under the guidance of Dr. Dipen Patel and Dr. Grishma Pujara. We do have two experts, Dr. Sheila Iyer ma'am. She's a known in NNF Gujarat. She is a professor and head of the Department of Neurology in Baroda Medical College, SSG Medical College. She was a past president of NNF Gujarat, and her keen interest in KMC is known to all of us. So we welcome Dr. Sheila Iyer ma'am.
Sorry to interrupt you,
Thank you.
sir.
Yeah, Ruparna.
The thing is, the person sharing the slides, sir, please, I would ask her to make it full screen, sir.
Yeah.
It's not in the slideshare mode.
Yeah. Toral, make it full screen. Full screen. Yeah. Toral, just stop once and then start again because this is still not full screen. Stop screen sharing.
Good afternoon, everyone.
Toral, just listen. Toral, listen to me. ऊपर ना वहाँ पे slide, ऊपर slide show लिखा होगा, वहाँ पे start from first slide लिखना, click करना. ऊपर slide show लिखा होगा, start from first slide. Click on that slide show ऊपर जो लिखा हुआ है. Start from first slide.
Toral यहाँ पे slide show.
And start from first slide. Click on slideshow and then click on start from first slide.
I think first stop sharing and then again reset. Yes.
So by the time she is doing this, I'd like to introduce our today's second expert, Dr. Sachin Shah. Dr. Sachin Shah has done his MD Pediatrics and DM in Neonatology. He has done in fellowship in Neonatology as well as Pediatric Critical Care from Australia and Canada. Having more than 25 years of teaching experience, he is one of the good teachers we are having today. He is having more than 50 international publications with the Cochrane Reviews, and that is one of the big achievements. He is also a reviewer for the Cochrane collaborations, heads 35-bedded NICU in Pune, and he has been credited with intact survival of smallest baby of 24 weeks. So we welcome Dr. Sachin Shah sir also. Thank you. And now over to Toral, make it full screen. Today, I think Toral is having some issues with the Zoom. So Toral, no issue, you can just start. Resume slideshow is one thing which is there coming.
I think there are people helping to help her, but still it is not working.
No issue, you can go to the second slide, Toral, but start because we already have 10 minutes.
Okay.
Yeah.
Good afternoon, everyone. Myself, Dr. Toral Gandhi, DM Neonatology resident at Pramukh Swami Medical College, Karamsad. I am presenting a case of 13-day-old female newborn. The LSCS delivered baby on 6th April 2023.
Go to next slide.
Gestation age was 29.6 figure. Yes, sir.
Go to next slide. Your second slide is not visible.
This one is the first slide for my presentation, sir.
Prasant, can
This
you
one
see?
is the second one.
Toral, do one thing, forget everything. First do stop sharing.
Okay.
Then go to the PPT presentation.
Yes.
Make slideshow either by pressing F5 or from the slideshow button. Done?
Yes.
Come to the Zoom again. While sharing a screen, select full screen. The first option which comes, screen. Are you able to see the option?
No, there is a share screen, but there is no option for full
On
screen.
first, on left, topmost basic first will be screen. Screen, whiteboard, and yeah.
Yeah.
Fine, done. Thank you. Yeah.
What's the point of being doctor if you can't do all this?
Toral, continue.
Okay. I am presenting a case of 13-day-old female newborn with a LSCS delivered baby on 6th April 2023 with gestation age is 29.6 weeks with birth weight was 950 grams. and on antenatal history of the mother. Mother is 21-year-old primary gravida with active marriage life of 1 year. Pregnancy was diagnosed with a urinary pregnancy test on a private hospital. And the LMP, mother's LMP is 9 September 2022 and EDT is 16 June 2023. Pre-pregnancy weight, mother's pre-pregnancy weight was 50 kg and blood group is AB positive. During the first trimester, mother had taken the regular antenatal visit at private hospital and she was tested negative for HIV, HPCG and VDRL. Folic acid was taken regularly and there is no history of fever, hypertension, diabetes, hypothyroidism and rashes during the first trimester. Mother's HB was 12 gram percentage. During the second trimester, both iron and calcium tablets taken were regularly along with folic acid. There is 2 doses of TD was taken. There is no history of gestational diabetes, mellitus, and anemia. There is no USG was done during the first and second trimester. During the third trimester, patient developed high BP in the 7th month of pregnancy, and the tablet. So for that, antihypertensive was started. Tablet levitalol, and tablet mifepristone was taken. In view of the uncontrolled hypertension, she was referred to our hospital for further management. So, in our hospital, injection levitalol and injection magnesium sulfate was given. There is a full course of antenatal steroid was given, and mother's weight during the third trimester was 60 kg. The ultrasonography is done, which showed a single live intrauterine fetus with cortex presentation with adequate liquor and with severe fetal growth restriction with an absent diastolic flow in the umbilical artery. Expected fetal weight was 890 plus minus 90 gram. There is no history of fever, burning micturition, convulsion, false smear liquor, and leaking PV or bleeding per vagina. In the perinatal history, in view of the fetal distress and meconium liquor, lower segment cesarean section was taken and with under spinal anesthesia. A very preterm live baby was delivered at 7:18 p.m. on 6th April 2022. 23. And then immediately, as baby was not breathed immediately after birth, so immediate blood clamp was done and baby is.
Question for you in your history part.
Probably, Toral, till our delivery, we could have some questions and some interaction before we go to the postpartum course.
Okay.
Okay. This is a 21-year-old mother who has gone for regular antenatal care. Till she developed hypertension, everything was normal. Unfortunately, not a single scan there. Does this happen very commonly in a private setup?
Ma'am, this is generally not happen regular basis, but a mother and the family background was there illiterate, so they had taken visit, but they advised for USG, but they didn't done any USG.
Okay. Normally, what do we advise?
Generally, we are advising for USG.
If a single scan had to be done, or that when would you like to do it?
Ma'am, first USG at 7th week, that is dating scan for the detection of the cardiac activity. Then either on at the 11th week, P or the there is a knuckle translucency and nasal bond, and then followed by 18 to 20 week for anomaly scan, and then it is a 28 to 32 week, that is growth scan, and ultimate at the just 38 to 30 more than 36 week, that is again growth scan.
So out of this, if only one had to be done, which one would you have preferred?
Ma'am, 18 to 20 week anomaly scan, that is the necessary. This is the one we should prefer if no USG is done.
Okay, what would have been the factors when at your institute severe growth restriction was diagnosed in this 29-weeker when there was no other data available? So what factors would have made them conclude that she has severe growth restriction?
Because of
Your
the
expected fetal weight was 890 plus or minus 60, so around 950, and exactly it has turned out to be 950. But the comment is there is severe growth restriction.
Yes, ma'am.
So how do we diagnose? I mean, when obstetrician or the sonologist tells us that there is severe growth restriction, what are the parameters taken? Because this was a single scan.
Ma'am, there is an umbilical artery with blood flow, and uterine artery and placental insufficiency we will see. And
Does that tell us growth restriction? Umbilical artery blood flow.
and then we will see the
Anybody else? Any of the other students wants to answer?
ಆಪರೇಷನ್ ಮಾಡ್ಕೊಂಡು ವಾಪಸ್ ಬಂದೇ ಇಲ್ಲ
fundal height we see.
Now we are talking with radiological findings. Fundal height, yes.
Cerebropresental
To predict severe growth restriction in a 28-weeker when your expected weight to put it as 9 weeks. And the expected gestation is also 29-weeker.
Ma'am, middle cerebral artery blood flow.
Dr. Prasad, please mute yourself. Dr. Prasad.
There is a lot of background noise.
Dr. Prasad Ram, please mute yourself. Or
બધાને મ્યુટ કરજો ને તમે પ્રશાંત.
that is with the Rutuparna, please mute all except Toral Gandhi, Sheila Iyer and Sachin Shah. Thank you.
Yes, sir, doing, sir.
As a neonatologist, Toral, would we question something to our perinatal colleagues, I mean obstetric colleagues, when they
Sir, I have muted all the participants who are talking. Please, I would ask to unmute themselves. Right, sir?
Sheila ma'am, you are muted.
Toral, unmute yourself.
Yes, sir, I had done.
Okay, so one was, we wanted to know what were the ultrasound findings which were telling us that there is severe growth restriction. What were the other indications which told us that this baby needs to be delivered? There was a compromised fetus. Agreed.
Yes, ma'am. NST, non-reactive, that is NST. That is,
we would go ahead with this particular preterm delivery, high-risk pregnancy in a young primary mother.
So that is a young primary mother, teenager, and there is a severe growth restriction, and there is an absent diastolic blood flow in the umbilical artery, and there is a non-reactive ST. If there is a non-biophysical profile is more than 6, there is again indication for the delivery.
So did we have, other than your Doppler study, any other finding akin to a compromised fetus which needed to come out early?
The lead is, yes, ma'am, non-reactive NST lead deceleration, that is the indication for.
Okay, which
And
was
there
there
is a
in this
NST.
particular fetus?
Yes.
Okay. You said meconium stained liquor. So was there a PPROM?
There is a, no ma'am, there is a note was of PPROM, but there is a mother developed a hypertension, and then on next day they is admitted over here, and meanwhile in 12 to 24 hour duration, there is a developed of the fetal distress and baby passed the meconium in the amniotic cavity.
So, okay, during opening the C-section only, you could notice that there was meconium stained liquor.
Yes, yeah. There is no
Okay,
previous
how
history of
common
the
is
MSR.
meconium stained amniotic fluid in preterm babies? This is a 29-weeker. If you see a meconium stained liquor, what comes to your mind? How common it is? Does it
Generally
give
it
you
is
any other
common in the
risk
post term.
factor?
There is a, because of the fetal distress, and there is a because of the absent end diastolic blood flow, and there is a pregnancy into, there is so high BP, so it may be possible that there is past the meconium.
Still, we see so many preterm babies. We don't see commonly meconium. So it's how common or how rare it is to see meconium stained 29 weekers. Usually, anytime meconium stained, we would look at a baby who is term or post-term. It can occur in preterm, I'm not saying no, but can you just narrate how common or uncommon it is, or the usual incidence? And what would you keep as a second DD if there is a meconium stained Liker?
Generally 62% is the more common in the term or post-term babies, but around 10% is common in the preterm baby. So there is less likely in the preterm baby.
Is it 10% or still less, Toral? 10 would be quite significant. We all should be seeing MSAF in preterm very commonly.
Less than 10%.
Any other PGs want to answer? Yes, in chat box, probably there is another DD which is given as listeria.
Yes, ma'am. Economistly Liker, that it can develop the MS, that is called listeria.
So, is there, why I asked you for PPROM was there any possibility of sepsis to be suspected in this child? Or did you, as per history, mother didn't have any diarrhea?
There is no history of the diarrhea.
Okay, to tell you the incidence, less in preterm, the incidence of meconium stained in less than 36 weeks, it's around 3 to 4, and less than 30 weeks, max is 4% reported. Okay, so it's not as common as 10%. It's very, very uncommon. Okay, Sachin, if you have to comment anything for further on the antenatal before we go ahead further.
Dr. Sachin, unmute,
we
please.
would take the fetal growth parameters at some other time, because otherwise we'll not have time enough to go ahead in the case.
For section here, Toral, was it done for fetal indication or maternal indication?
There is a maternal or fetal both indication, because there is absent end diastolic blood flow with a fetal distress. So that is the indication for the termination of the delivery and taken the LSCS.
Absolutely agreed. Okay, go ahead. And what is the accuracy? What is the sensitivity, specificity of biophysical profile at 29 weeks? Can you rely on those parameters, or which is the most accurate parameter? Like if you want to monitor the fetal well-being,
there is a cardiac topography, CTG and the NST.
Is it, or is it the Doppler?
Doppler is the most reliable, but that is the USG radiological finding. But if we are monitoring the baby mother in the labor room, continuous monitoring is possible with NST and CTG.
Okay, but as far as fetal well-being is concerned, like we would be monitoring mostly using Dopplers, isn't it?
Doctors. Yes, sir.
Okay. Okay, I think that's good enough for now. Let's go ahead.
Yeah.
Go ahead, continue.
That is in the perinatal history. The lower segment cesarean section was taken in the view of the fetal distress with meconium stained Liker, and there is a very preterm live baby girl was delivered at this 7:18 p.m. on 7:18 p.m. on 6 April 2023. The baby was not breathed immediately after birth, so there is immediately cord clamping was done, and there is baby received a plastic crepe. So after initial step of resuscitation, baby was still apneic, and there is a heart rate was less than 60 per minute. So bag and mask ventilation was given for 30 seconds, and there is after given of the bag and mask ventilation, there is an increase to heart rate 80 per minute, but there is no spontaneous breathing or no spontaneous activity. So baby was intubated and given the bag and tube ventilation was given. And there is a heart rate gradually there is a heart rate improved to more than 100 per minute, and then baby was shifted to our NICU. So there is a Apgar at the 1 minute was 2/10 and 5 minutes was 7/10. So baby was shifted to the NICU or at the time of admission in NICU, baby's vital was temperature was 36 degrees centigrade, heart rate is 136 per minute. respiratory rate is patient was on a Bagan tube ventilation with spontaneous respiration was present, and SpO2 was with Bagan tube ventilation was 94%. CRT is 3 seconds. Respiratory system air into bilateral equal clear. CVS S1 to normal, and Criton activity CNS there is activity was fair. So there is a in view of the birth asphyxia, perinatal asphyxia, and Bagan tube ventilation, baby was kept on the mechanical ventilations with SIPPV mode. PEEP was 6 and peak respiratory pressure was 15, rate was 35, and FiO2 was 60. Yes, in our NICU, then we have started the treatment. So we had just first taken the umbilical artery venous catheterization we had done, followed by ABG, blood culture sensitivity, and coagulation profile was sent. There is IV fluid treatment, IV antibiotic, injection caffeine, injection vitamin K, injection calcium gluconate in the maintenance dose was started. Chest X-ray invasive cranium was done. In view of this, there is a prematurity. And injection Surventa we had given. There is a 4 ml through ET was given within 2 hours of the birth. That is the early rescue therapy we had given. We had followed. So as baby was the 950 gram, that is extremely low birth weight. So we kept the baby in the.
Toral, I have a few questions on the management aspect. Yeah.
Yeah.
Can you go to the previous slide? Yeah. So just quick questions. What would be the best mode if you have all the ventilators in the world? Which is the best mode to ventilate a ELBW baby?
High frequency oscillation HFO.
No. In conventional, I'm talking.
SINV mode.
No.
So volume trigger.
Volume guarantee. What about volume targeted ventilation?
Volume targeted ventilation, there is a tidal volume 4 to 6 ml per kg is delivered.
What does the Cochrane review tell you by Wheeler? What does it tell you? Use of volume targeted ventilation decreases the incidence of chronic lung disease. Yes, BPD. So small decrease is there. So it can be used as a preferred mode of ventilation, but unfortunately not everyone has it. Okay. So as far as your initial ventilatory settings are concerned, you're needing a FiO2 of 60%, you are needing a PEEP of only 15 in a 29 weeker. Do you think like you have achieved adequate balance of ventilation, or there is a mismatch between your pressures which are delivered and the FiO2? Or you are happy?
Because PIP was 15 and PW was 6, there is adequate chest rise and there is adequate ventilation is also. So the baby would tidal volume 6 ml per kg generating. So that is the adequate ventilation starting according to us. And baby was maintaining SpO2.
So you are using a time cycle pressure limited ventilation, TCPL. So how much tidal volume was being delivered?
In time cycle pressure ventilation.
Did you monitor the delivered tidal volume?
No, sir.
What ventilator were you using? What type of ventilation were you using?
Actually, sir, we are using ventilator SLE ventilation, and there is a SIPPV mode we had started, and gradually we have tapered to SIMV mode, synchronized intermittent positive pressure.
Yeah. Correct. So that's a time cycle pressure limited, right? Okay. So go ahead. Other thing, like when you talked about, like when you wrote down the treatment plan, like is that how you would prioritize? Would you do the lines first, or would you give surfactant first?
Actually, sir, if there is ideally, if the baby is less than 26 weeker or there is a less than 28 weeker, there is a mechanical ventilation at birth, but the prophylactically surfactant therapy 15 to 30 minutes at birth we can give. But just the baby is shifted to our NICU, and there is a early rescue therapy is also comparable with prophylactically.
Absolutely, you are not prophylactically. Here you have intubated the baby, right? The baby has been intubated in view of like prematurity, perinatal depression, RDS for multitude of reasons, right?
Yes.
So only I have an issue as far as you go to next slide. I have an issue with the prioritizing things. You have written that umbilical lines were done first. I don't think you would have done that first.
Okay, Sachin, I would also just, other than the baby required resuscitation, any other parameter which told you that this child is perinatally asphyxiated?
Yes, correct.
Because our ACOG or any other, our obstetric colleagues would be very upset if we very loosely put that the baby was asphyxiated. They'll be waiting to pounce on us.
True, very true.
Because this child has a morbidity of preterm, your high BP, many maternal risk factors. Absolutely agree. Actually, severe growth restriction, which was reported, looking at the parameters of the baby also, I would not agree that this was severe growth restriction.
No, agree. Yeah.
And
Same
similarly,
here.
acutely the uterine artery flow and Doppler study could have been compromised. And there was maternal BP, which was not well controlled. So both mother
Correct.
and fetus, you needed to deliver out the baby. I mean,
Correct.
your point of arguing that C-section was taken was both reason, because maybe mother's hypertension would have been worsened. She might have thrown a convulsion. Whether she had any proteinuria or she was fitting into pre-eclampsia or convulsion wasn't there. So I don't know about eclampsia, but there could be some other factors in mother.
Edema was there, ma'am.
Okay. Was there a proteinuria?
Ma'am, proteinuria just and not more than 300 milligram per deciliter, but there is a urine protein creatinine ratio was a 0.2
Okay.
in the urine examination.
So what made you put the diagnosis of perinatal asphyxia?
So in the perinatal asphyxia, because ma'am, baby at the 1 minute Apgar was 2/10. So there is a, according to the NNPD guideline, there is but if the 1 minute Apgar is the less than 3/10. So that can be the perinatal asphyxia. And another aspect, there is a fetal cord blood is a pH is less than 7, and fetal hypoxia and hypoxemia and hypercarbia. So that can be possible. That is a perinatal
Did we
asphyxia.
have cord pH?
Ma'am, we don't have the cord blood pH.
Was
But
there
that-
and very soon an ABG was done soon
Yes,
after
yes, ma'am.
delivery?
That in the pH is 7.2, which I have shown, and there is a
At what hour of life was that 7.2?
so ma'am, because they are around the 1 to 2 hours of life, because when we had done umbilical arterial catheterization, from that we had taken that ABG.
Okay. So if pH might have got corrected
So
because
this
we were
slide is-
ventilating. So anything else which could help you? That there was acidosis?
Bilactate or bicarb. pH
so-
7.2, bicarb is 14.4. So that is also sign of the sepsis. Lactase is 2.2, but that is not that much sepsis. But PCO2 is a
lactate would
35.
suggest you what?
Ma'am, pardon?
Lactate would suggest you what?
So there is also acidosis if there is. Lactate will increase. And base excess is, ma'am, 13.5. That is also suggestive of the sepsis, acidosis.
Okay. Okay.
Should I go ahead?
Next slide. Yeah,
Yeah,
go to
yeah.
next slide.
Just a treatment.
Normally,
After
you
that-
said chest X-ray, USG. When would you prioritize USG after birth? Chest X-ray, naturally, in such a child with lines, ET, everything you would do. But when would you like the first USG to be done in a 29-week premature?
20, yes, in 29 weeker, we will do on the 0 to 3 days, first USG. So, and then 7 to 10 days, followed by at the 28 days of life.
So there is no emergency of doing it immediately there,
Yes,
unless until you are using USG for your line placement, other things, and you just
Ma'am,
put
just
in
scientists are advising, but we don't had done immediately after birth. After that, the initial hemodynamic management. After that, we had done the USG cranium.
go ahead.
As baby was extremely overweight, so baby was kept in incubator with relative humidity was 80%. There is an in view of the deranged coagulation profile, injection FFP at the 10 ml per kg was given. So on the 12th
Just
hour
a
of
minute,
life,
Toral. This deranged coagulation profile at what hour of life?
ma'am, we had sent that 5 to 6 hours of life. We had sent the coagulation.
What would you consider abnormal coag profile soon after birth or in the first 6 hours in a pretermer?
Actually,
would
ma'am,
mean an
this is our unit protocol. We are sending the coagulation profile by preterm babies to see that there is a, because of there is a perinatal asphyxia, so there can be a deranged coagulation profile. So we, in view of the perinatal asphyxia, we have
But then
sent.
what will be your cutoff to or indication to transfuse them with a blood product?
Ma'am, there is a INR more than 1.5. That is the indication for more than 2. Sorry.
So what was the profile here?
Ma'am, there is a PD was 33 and INR was 2.9, ma'am.
This is you've done after probably 12 or 24 hours?
No, ma'am, there is immediately after birth, which along with the ABG, we had sent the coagulation profile. So that is 6th April, which data is written over here.
What could be the cause for an abnormal coag profile in a preterm soon after birth?
Because of the first, in this case, there is a perinatal asphyxia, but there is because of the hepatic immaturity.
Does it immediately, okay, the child had probably some degree of naturally chronic hypoxia, or at least for last few hours or days, as there was severe hypertension and a Doppler study was altered. That leads to fetal derangement of coag profile?
Because maybe there is
at
chronic
birth,
hypoxia.
what would be normal at birth?
There is coagulation profile will be normal at birth. If there is a chronic hypoxia, so then that can be possible. If there is a derangement of the coagulation profile.
Because in an asphyxiated child, hematological abnormalities and coag abnormalities do occur, but isolated at birth coag abnormalities.
Because of the pregnancy-induced hypertension, is also can cause.
What it leads to? Pregnancy-induced hypertension. The fetal abnormalities are what kind of abnormalities that one would have?
Neurodevelopmental outcome also and
thrombocytopenia
in the vein.
Okay, so what would you call thrombocytopenia? Then what else?
There is a DIC if there is a deranged coagulation profile with a thrombocytopenia in the sick baby. That can be differential.
Because you didn't have sepsis here. You didn't have sepsis here. Your cultures were negative.
Yes, ma'am. And CRP was also normal.
Normal. And even if your coag profile with a normal platelet count comes as abnormal, what are the, where there could be, and clinically, if not showing any signs of bleeding?
In the well baby, if there is only coagulation profile alternation, so if there is a vitamin K deficiency, hemorrhagic disease of newborn can be possible.
No, Toral, I have a comment, like there is no role for doing routine coagulation tests. Like we have the NNF guidelines, which were published in 2019. There is no role for doing routine coagulation profile. There is no role for routinely giving like blood products for abnormal coagulation tests if there is no evidence for bleeding. I think you should go through those clinical practice guidelines of NNF. They are freely available on the website.
Yes, because sometimes even the PT, PTT are so much lab dependent. I mean, if you do not have well controlled and properly collected, you might get it altered. So we do have to really look for a reason that really, yes, whether this can be abnormal and do I need a product.
And we don't know what is normal. We don't know what is normal, what is abnormal.
This was our unit protocol, so we are continuing.
Okay, probably we can review it. Okay,
Yeah.
that's
Yes.
what the message would be.
Again, I go through the guidelines, then we will review. See.
Yeah,
Please go.
let's go back to your management protocol. I would have just little suggested that if you had given us a little hour-wise or at this, because or I understand that your sugars on delivery and the first 24 hours were normal. Your calcium was normal, and your hematological profile also in this child was normal. Because at 12th hour, on what GIR did you find that the baby became hypoglycemic?
We are continuing with the GIR. Previously, that is also 5 mg per kg per minute. According, we are giving the 10% dextrose at 30 ml per kg. We have started. That was the 5 mg per kg per minute GIR.
One minute. 10% dextrose to a 29 weeker. At how many ml per kg would you start?
80 ml per kg per day.
Okay.
So at the 12 hour of the baby developed the hypoglycemia. At that time, RBS
prior to that, at 1 hour, 6 hour, the glucose were normal?
Yes, ma'am. Previously, all RBS was normal. That is the first episode.
Okay.
And
whenever a low reading on infusion comes, what are the checklist points that you would check? You would treat definitely, but what could be the errors that you would like to rule out?
Yes, there is a blockage of IV line, or there is IV line fluid is not going properly, or there is a IV line excess maybe out. So something we need to check first that part.
And I think umbilical venous catheterization.
Yes, there is a blockage or we have not started, so that can be possible. There is a proper fluid administration if not done, that can be possible. First, we need to rule out that.
All that. Okay, this was your glucometer reading or your lab reading?
This is our glucometer reading.
Okay. Concomitant or a later blood plasma glucose in lab was done?
Yes, ma'am. That time that is the RBS with lab plasma is not sent. That time just we had given bolus and we had increased GIR from 5 to 6.
Normally, what do we do when we get a reading which is low?
So first we give the
Normally
bolus
4
and
to 6 is our recommended GIR.
Pardon, ma'am?
Recommended glucose infusion rate for a preterm?
4 to 6 mg per kg per
minute. So this was already going at 6, isn't
yes,
it? Okay. You got it low, you gave 1 bolus. What happened after that?
After that, ma'am, RBS was from 34 to they increased to 70. And there is after that, from 12th hour to life to day of life 4, there is no episode of hypoglycemia. We are monitoring RBS 8 hourly.
Okay, you are monitoring, and your requirement of glucose also did not go beyond 6 to 8.
No, ma'am. 6 mg per kg per minute, we are giving the glucose infusion.
So for 72 hours, you did not have, except this one single reading of hypoglycemia, you did not have any hypoglycemia.
Yes. Okay. So as the respiratory distress decreased, there gradually ventilator parameter were dropped. And then in that 24 hour of life, there is one sepsis screen. In screening 2D echo had done. And there is sepsis screen was not, HB was 15.3. Total count is there 34,500. A platelet was 66,000 and CRP was 2.3. So at 36 hours of life, baby was extubated and kept on the nasal CPAP with PEEP was 6 and FiO2 was 30%. And there is no vitals was no, temperature was normal, respiratory at 60 per minute, and CRT is the 3 seconds, PO2 is 94% with FiO2 30%. And then at 48 hours of life, we again repeated the sepsis screen and population profile, right? That was the sepsis screen. There is a platelet count was from 66 to decrease to 25,000 and population profile was normalized. So because in view of the thrombocytopenia, we had given an injection platelet at 10 ml per kg and then trophic feed started.
Okay, what could be the cause for this thrombocytopenia that you were seeing?
Because there is a perinatal asphyxia and there is a PIH that can be caused the thrombocytopenia in this baby.
Would you attribute it to perinatal asphyxia? Because what other symptoms of perinatal asphyxia you encountered in this particular child?
There is only Because there is a Apgar at the 1 minute is there is a 2/10. So that can
Yeah,
that is the-
what we say usually post asphyxial multi-organ affection is there or not. So one of them would be your hematological.
hematological abnormalities. But there
But
is
what else? Would we only isolated thrombocytopenia? Would we go and say this is post asphyxial?
it can be because of the prematurity. Hypertension more likely because there is no other CNS or RS. There is a respiratory distress definitely, but there is a CVS and other GI. There is no other involvement.
Which is the most common organ involved post asphyxial?
Brain, neurological,
We usually look at the definition is multi-organ.
multi-organ dysfunction. But
Yeah,
Caesar
so
and
which is the
encephalopathy-
most common of all? Is it the thrombocytopenia the only one?
No, Caesar is the most common.
That's a neurological thing. If I'm asking you amongst the various systems, you said CVS, no affection, lung, this child had HMD, you're not calling it an asphyxial lung injury.
That is most common CNS. Then there is other is in the respiratory distress, RS, CVS. There is a congestive myocardial dysfunction, valvular abnormalities, and there is arrhythmias. And then is a CNS, RS, and there is in GI there is an NEC, feeding intolerance, abdominal distension. And there is a hematological, and there is a hepatic dysfunction is also renal. There is acute tubular necrosis. Can be
So more common is renal.
yes.
Okay.
Yeah.
Many of them, unless until investigated, you may not know the renal dysfunction.
Yeah.
Okay.
Urine output was normal. We are monitoring, ma'am.
Okay. Would it be most of the renal failures or renal dysfunctions are oliguric in prematures?
No, that can be polyuric.
Only on output we cannot comment. Okay.
Yes.
Especially in a 29 weeker where the nephrogenesis is not yet even complete.
Yes. So we had done RFT on 3rd
What are the
day.
indications for giving platelet transfusion?
Ma'am, there is a platelet is 25,000. So because in the less than 30,000 baby, unless of the in 30,000 baby we need to transfuse. Your 30 to 15 49,000 if there is a baby less than 1 kg or less there is a 1 week, if there is a post surgical repair in the last 72 hours, or there is a hemodynamic instability, concurrent coagulopathy, we then need to transfuse. And there is a, if more than 1 lakh, there is no indication. And along with 50,000 to 1 lakh, there is if there is IVH, and so we need to transfuse the platelet.
Okay. Any error which can cause low platelet count on your counter?
Yes. PSCM we need to see.
Pardon?
PSCM, peripheral smear. Because
Yeah. So what can give you a low
clump of the
counter?
platelet? So we need
Pardon?
to see. There is a clumping, so we need to review with PSCM in case of thrombocytopenia.
Okay, so that's what I wanted to, because what can very commonly cause erroneously low platelet, though they are not there in the blood?
There is
Because
a
your
blood
baby did
clump
not have
product,
sepsis.
blood clumps that can be considered as a
As an evidence for what?
megakaryocytes, we need to evaluate. There is a peripheral smear.
Something more?
Pardon?
In which bulb do you collect your CBC?
ADTA.
Okay. Do you have micro vacuity or you are using it the adult vacuity and you are collecting
Micro
it?
vacuity we are using, ma'am.
So
1 ml blood.
So what can be more than it can cause if your blood collected compared to or EDTA, or EDTA is more in your vacuity, you will get a low platelet.
Oh.
Okay, so as you said in peripheral smear, or you are really confirming, then the thrombocytopenia becomes real. Okay, yeah, go ahead.
So what bulb will you send it in if you want to confirm? Toral,
Pardon?
what if you want to confirm, if you don't want to use EDTA bulb, what other bulb can you use? What, or vacuum? Anything else you can use?
there is a fluoride.
Fluoride you use for what, Toral?
No, so RBS, ma'am. Plain serum plain illiterate.
Citrate. Yeah, somebody answered citrate. Yeah. Good. Why is your WBC count high, Toral?
That can be because of the hemoconcentrate.
Is it?
Hemoconcentration cannot give.
No, but
Actually,
that
I'm
is my
quite happy that you had a 15 gram HB, though you didn't do a delayed cord clamping. You immediately clamped in view of baby needing resuscitation. So we didn't follow even delayed cord clamping or optimum cord clamping time. Still.
Yeah. So intrauterine stress. So how will you differentiate on a smear? If you look at the smear, what will you find?
Fine.
So what should you tell your hematologist to, or like the pathologist?
in the
What is corrected WBC count?
Corrected WBC count.
In the corrected WBC count, just WBC with
See the counter, you're right. The counter, the coulters that we use, they will measure all the nucleated RBCs also and label them as WBC. So you will have to differentiate. So most of these are nucleated RBCs. So the smear, when they look at the smear, they will give you the corrected WBC count, which has been adjusted for the nucleated RBCs. The nucleated RBCs are increased whenever there is intrauterine hypoxia, stress, or whatever reasons. Okay.
Which would other factors that you would add if you had to do a sepsis screen, because you've been sitting at a low platelet, high count, something more you would have done. You have a meconium strain liquor, so whether it was listeriosis or a maternal sepsis, we didn't examine the placenta, so we have no idea what was there any possibility. The culture 36 hours yet not growing anything.
So, ma'am, there is ANC band cell. So
did we look at anything of that?
Yes, ma'am. We had seen. There is an ANC that is according to, there's a preterm. So on the Mozino chart we have seen. So according to ANC, there is a no in the range of the ANC count that is a normal in the range. That is 30,363, and there is a serial trends of ANC. So there is a no decrease in the ANC count. So which is sign of and a band cell immature to total neutrophil. So band cell is not more than 10%. More than 20%.
25,000 you gave one platelet. Even on 10th, again your count fell down to 10,200.
No, ma'am, so that is a typing mistake. Sorry, pardon for that.
Yeah,
because 25,000 we already transfused, isn't it?
Yeah, yes, ma'am.
Then again it is 10,200.
That is the one next 200. That is for typing mistake.
Okay, go back to your.
36 hours of life, we extubate the baby and capped on the nasal CPAP. And the vital flows temperature was normal, respiratory rate was 60 per minute, CRT is 3 seconds, and SpO2 is 94%. In the 48 hours of life, we repeated the sepsis screen and coagulation profile. And the coagulation profile was normalized. And then on day of life 4, there is baby again developed hypoglycemia. So for that, we have to increase GIR from the 6 mg per kg per minute to 12 mg per kg per minute in a stepwise manner. And
what was the feeding? What was the fluid which was going on day 4?
Ma'am, there is a day of life 4.
What are your protocols? This was baby who was on CPAP, who otherwise was extubated, hemodynamically stable, not on any inotropes. What were the
just
feeds that were going on? You said trophic feeds were started at 24 hours.
Ma'am, at 48 hours we are started.
Okay, you had started. With what amount do you start trophic feeds?
10 ml per kg per day.
Is it, what is the recommended trophic feeds?
10 ml per kg per day.
Sure.
5 to 10, ma'am. There is a range.
which category you would be so low? So this would be hard.
Yes, ma'am, there is absence
MEN
of
per se, what is the minimum? Not 5 to 10 total.
1 cc 6 hourly.
So that would not even, that would be less than 5 ml, 1 cc 6 hourly. I know this used to be a protocol when people were very restrictive in enteral feeds.
Yeah.
I think most of
Actually-
our NNF CPG guidelines as well as most of the units in India are not very restrictive as far as. Do I agree, Dr. Sachin?
Yeah, I agree. I think Toral, for your exam, it would be very of lot of benefit because the NNF guidelines are very useful. When you quoted the transfusion guidelines also, I was pretty sad that you didn't quote the NNF guidelines. We are very clear on that. And for trophic feeds also, the starting point, if the placental insufficient, like if there is Doppler
Yes.
abnormalities are there, you could start slow. Otherwise, you can start anywhere between 10 to 20 ml per kg per day.
1
But
cc 6
10
hourly would be just 4 ml. Okay,
Yeah.
here you had some degree of Doppler study, which were this. Later on, this baby has not been, I mean, the stool passed, if peristalses are there are no high aspirates, no distension, you don't remain so restrictive.
Yeah, it's very, very like, and the grading up also like could be up to like nearly 30-35 ml per kg per day. And there are a lot of Indian studies which have shown that you reach full feeds faster without increasing the incidence of NEC.
NEC or feeding. There could be one particular baby who gives a problem to us while grading up and we have to come back or revert back to little low. But 1 cc 6 hourly comes to very, very those severe IUGRs where the weight is also
500 grammer maybe.
Yeah, maybe.
Then we have
And-
started 10 ml per kg per day. That is the 1 cc 3 hourly. We have started in that manner in the trophic feed. That is because of the in view of the there's a absent of an diastolic flow, there is a mesenteric vascular resistance and the altered blood flow. So we have started at 48 hours of life.
Yeah, fair enough. Yeah. So do you know the study on the basis of which you are making this recommendation or you are doing this practice in your unit? Any
Yeah,
study quote?
Yes, a Cochrane
starting at
review and
whether
the AIMS
people
protocol is
start on
suggesting
T1.
that is. So we are following that.
Okay, fine.
So in the day of life.
So now
for
on
the day-
4th day, was this baby being an ELBW, we are going to be very restrictive in enteral grading up, was put on any TPN or an
Ma'am, aminoven was started.
at
And
what
there
dose
is a-
and how much?
Yes, ma'am. We have started from 1.5 gram per kg per day, and then we increased
which
0.5
day?
gram per kg per
On
day.
which day?
Ma'am, at the
1.5
48
grams
hours
on
of life.
which day? Huh?
At the 48 hours of life.
Okay. And so day 4, how much was the aminoven going?
On the day 4, there is a 1.5. There is a 2 to 2.5 gram per kg per day was going. 2.5 gram per kg per day.
Okay.
So there is only we have amino in case of the lipid, because ma'am previously we have seen the sepsis in the from the lipid. So we are not starting the lipid. So we are giving the only aminoven in view of the parenteral nutrition.
So that is partial parenteral nutrition that you are giving, which is also okay.
Yes, ma'am.
So that's
Okay.
called as partial parenteral nutrition.
Parenteral nutrition.
Yes, ma'am.
Okay. Do you add any multivitamins or anything
No,
else
ma'am,
to
we
your?
haven't added. Multivitamin injections may be not added.
You're not adding. Now it was day 4 complete or day 4 beginning. Would you like to tell us what was the percentage of weight loss in this baby from birth to this?
Yes, okay. There is a initial, there is a
960 was your birth weight.
953 gram.
Okay, 953 was birth weight.
Yes, ma'am.
And what was the weight at day 4? Weight.
10 to 15% is because we are first, ma'am, we are keeping we have kept a baby in the incubator. So there is a before to reduce the insensible water loss and maintain the humidity also.
I agree entirely. But what was the impact of it is what I wanted to know.
So there is a humidity, so insensible water losses was decreased. So there is
Agreed, I agreed it
decrease
decreased,
in
but what
it.
was the documented weight, Toral?
you
initial
weigh the
1 week
Do you weigh once in 24 or 48 hours such babies, ELBWs, where we decide the fluid also sometimes accordingly? Did you do your electrolytes? Did it tell you anything? What was your status of fluid deficit or not?
Ma'am, we had done the ABG. So according to basis of that, only we had another serum electrolytes we haven't see or
But your ABG will give you the serum electrolytes, Toral.
no, ma'am, there is a so that is no rough idea. That is not exact serum electrolytes value.
Why? Why not? Why not? The point of care testings, most of the modern machines are 100 times accurate.
That is the
You use
blood,
a blood sample, like for such a small baby, like we would try to minimize the blood losses, right? So we would minimize the blood sampling volume that we are taking. So in that small volume, like ABG, you will get like your calcium, ionized calcium, lactate, electrolytes, and hematocrit. Most of the modern analyzers would give you those additional things. So it would be, I personally think that it would be like, we should not be taking extra excessive sample when it is not needed.
Yes.
So if you had to comment from what you got on your ABG sample, what would you comment?
That is in the sodium potassium, that is normal, ma'am. So there is
I
no
understand.
ma'am.
Calcium.
Pardon?
Calcium.
Calcium is 1.04. That is according to preterm, that is also normal.
So is it ionized or total?
Ionized.
Okay. So for your lab or for your this, it is normal, accepted. Potassium, you would consider it normal?
Potassium, ma'am, is 3.5 to 3.5 to 5.5 is the normal, but only there is 3.3 that is the slightly less. Not
okay, so what do you usually, you are making a partial TPN. So what type of fluid do you give after 36 hours or 24 or 48 hours? First 24 hours, actually you were on 10D. And this were your electrolyte reports.
Then in the general guideline, there is a guideline after.
Whatever your unit protocol is there, you may say.
0.45 DNS.
Because you are the one who are managing patients. So what do you do when you see this report? How do you plan out your fluid?
Okay, 0.45 DNS with the sodium and with the potassium.
What DNS?
0.45 DNS, ma'am.
What? I didn't get. That means
there is a 25 ml 10% dextrose and 25 ml NS. But actually, ma'am, we have issue with the GIR. So then we moved from that is a 10% dextrose to 25 because of it to increase the concentration of glucose. But after 48 hours, we have started the 0.45 DNS, that is 25 ml 10% dextrose and 25 ml normal saline. And we have added
half saline, half DNS.
Yes.
But with a glucose concentration of 10%.
Yes, ma'am. But there is according to, we have set the GIR 6 mg per kg per minute. According to that, we have changed the concentration also.
Okay, that you changed. But how much sodium and potassium you would give by 48 hours?
By 48 hours, initially we have give 3 milliequivalent per kg per day.
So that does your half DNS provides that or gives more?
Half DNS normal saline, 1 ml content 0.15 milliequivalent. So according to, and there is an antibiotic also gone, so there is also some amount of NS also going on.
So usually you have some calculation, because ELBW, your fluid and electrolytes,
we have all calculations.
Very important.
Yes, ma'am. We have all
how much potassium do you add?
Electrolytes.
Huh?
Pardon, ma'am.
And potassium, this child had 3.3, 3.5. Then
1 milliequivalent per kg per day.
Even on 10th, it is day 4, you are at 3.8. So how much is your maintenance that you give?
2 milliequivalent per kg per day.
Okay. So this child would require 2. So you correct that into your fluid daily calculation of fluid.
Yes, ma'am.
Does anywhere have a weight, a role in deciding the fluid therapy of a baby?
Yes, ma'am. If there, because there is a syndrome of SIADH, there is a fluid retention will happen. Then
No
it's-
SIADH, routine ELBW patient being managed in NIC. How frequently do you weigh them? I know minimum handling. I entirely agree with you. It
but
is how-
ma'am, we kept this baby on the minimum handling, but in our NICU protocol, we had generally doing weight once a day.
Okay, so that's what I'm asking. Day 2, day 3, day 4 weight of this baby.
Ma'am, this is minimum handling we kept on, so we didn't monitor weight on daily. So we just done on 48 hours. We had done 1 week, and after that, we had done on 48 hours basis. We are doing not
Okay.
daily. We kept
So-
on minimum handling.
Okay, I agreed. Does it make any difference?
There is a
Because child was extubated to CPAP, sometimes invasive ventilator inside the incubator, not to handle. Agreed.
so if there is a
Hmm.
but ma'am, because if there is because we are generally doing the calculation from the maximum weight, that is 953 gram, and initial
Agreed.
1 week there is definitely going to decrease on, so there is no much significant. We
And I
will
think
monitor
Toral,
daily
you
weight.
were making a very, very radical statement that there is no point if we are going to calculate only on birth weight. But say this child had a sodium of 148. Would I look at the weight or not?
Yes, ma'am, I will see.
What would it tell me?
There is because of the 148, there is a hypernatremia. So
Or
there
say
is
152.
so there is a
This
because of the
ELBW. I know
fluid
you are
restrictions.
doing it in an incubator, you are trying to minimize the fluid loss, but due to something. So there, what would help you?
So there is a hypernatremia, so we need to increase the fluid. So there is a maybe fluid losses, restriction of the fluid, that will create the hypernatremia, significant weight loss. So we need to see that.
Okay, go ahead.
So GIR increase up to 12 mg per kg per kg per minute, and then the,
So what was your
we are
minimum
diagnosed-
sugar here? When you went down as hypoglycemia, what was your glucometer reading and what was your lab reading?
there is a less than 45 mg per deciliter. If there is a less than 45, then that is a
Okay, so what was it? The exact value?
of baby.
Yeah.
Okay, so in the initially there was a 34, and then when we
That was
speed
on day
increase-
1, 12 hours. You said.
After that,
Then it got
yeah, when
corrected
we-
immediately to 70, isn't it? Yeah.
So,
So
then
now
with
day 4, when you required to go to 12 from 6, so what was your reading? And what was happening that you had to naturally jump to 12 and then to 18 also? That's what you have written.
Yes, ma'am. There is a initially every 4 to 6 hourly, there is a 35, 40, 42, 45, and 57, some kind of reading. This kind of reading was there.
Agreed, but didn't confirm with lab. Because this was a refractory hypoglycemia is what
Hypoglycemia.
we are concluding. Would you like to confirm with a lab or not?
Yes.
Toral, if lab test was sent, but you are not aware, just say you are not aware of it.
Yes. Yes.
Yeah, fine. Whenever it goes to critical or refractory, we would need that single episode of 34 we can ignore because it got corrected immediately. And next reading you had 70.
So Dr.
Because
Anis has
when-
replied, it was 22 when
Okay.
lab sugar was sent simultaneously. It was
Okay.
22. Yeah.
So you were augmented from 8 to 10, 10 to 12, 12 to 14, and you almost went to 18 milligram is what you have probably mentioned.
Yes, ma'am.
Okay. So what are the causes of hypoglycemia here?
There's a
What you
hypoglycemia. There is
thought
a-
of it? At what level would you think of critical sampling?
In the case of the resistant hypoglycemia, there is a we need to send the critical sample at the time of the hypoglycemia only. There is a serum insulin, cortisol, ketone bodies, and a free fatty acid level we need to send. And
Yes. So what was your glucose and concomitant insulin at that time?
In the normal guideline,
We would talk about your patient, Toral. Isn't it?
So in in our when we had sent that sample, that RBS was 25 and the insulin
25.
but the insulin report was the less than 1.6 time, but because there is a strict precaution was required and there is a sampling, we had sent the sample and then immediate should be run. So there is a
So you would have naturally, you knew about it, so you would have taken care of. So what is important? It is the insulin level or something else which is important?
Because ma'am, there is a because this is the serum insulin level is not going in our setup, so we have sent to some outside. So there is and because there is a sample running, there is a 24-hour gap when send the sample and there is a running machine. So it can be, but there is in this case there is maybe transient neonatal hypoglycemia can be possible. Because after after 10th day of life, we generally resolve hypoglycemia and we have we can taper even a digoxide and then followed by we omitted the digoxide also. So it can, in this case there is a transient neonatal hypoglycemia.
No, but as per our clinical documentation, what we have seen is the child had refractory hypoglycemia. Even giving so much of glucose, you were getting low glucose renin. So you can't call it transient neonatal hypoglycemia. If your insulin was low or within normal range, what is important? Is it insulin level or it is insulin glucose ratio? If you are low on glucose, your insulin becomes negligible in blood. But if your insulin glucose ratio is abnormal, then that tells you that there is definitely for concomitant this you are having. So what is normal insulin glucose ratio for a preterm or for a term baby in the first week of life? Because our glucose is usually low in neonates in the first week of life.
Yes.
Okay, it's more important is the ratio.
Yeah, sure.
Levels are more for adult and where they look for hyperinsulinemia more. For newborn, to call it as hyperinsulinemic hypoglycemia, your insulin contemporary to your glucose is higher. So glucose to insulin to glucose ratios are taken and the normal values would be 0.4 to 0.2, 0.4 to 2. Usually less than 0.3 comes when you have a hypoglycemia and no hyperinsulinemia. Go ahead.
So in view of the persistent hypoglycemia, glucose infusion rate was increased up to 18 mg per minute and injection octreotide subcutaneously was given and pediatric endocrinologist opinion was taken.
How frequently was octreotide given?
Ma'am, there is a
Before octreotide, did you give steroids to this child?
No, ma'am.
Okay. You directly. Usually our algorithm, does it give an option of steroids?
Yes, hydrocortisone, ma'am, we can, but there is a, it can be, can develop sepsis in a prematurity, so we have not given hydrocortisone.
Okay. But do we give for how long and how much hydrocortisone in the algorithm?
5 mg per kg per day BD.
Okay. Or one may give 2.5 milligram per kg, 6 hourly. So we didn't give, being a preterm, you were not, diazoxide is given for which cases?
I just said there is a resistant hypoglycemia.
You gave first octreotide. Sorry, octreotide are indicated when?
Ma'am, there is a octreotide.
Because you gave octreotide.
Octreotide, ma'am.
You had refractory hypoglycemia. So what was your diagnosis for hypoglycemia? Cause of hypoglycemia here?
Pardon, ma'am?
Your indication for giving octreotide, and what was your cause of hypoglycemia here? Which conditions we give octreotide or diazoxide? In which causative etiology of hypoglycemia?
Congenital hyperinsulinic hypoglycemia. There is a not controlling with hydrocortisone and hydrocortisone setting. There is a diazoxide is not available, so we are trying to arrange it. So meanwhile, we had given the injection octreotide.
Okay, so for that to prove it hyperinsulinemia, you need to do glucose insulin ratio. Okay.
Yes.
Okay. How much octreotide and how frequently?
Ma'am, there is a octreotide is 15 to 35 microgram per kg per day, and TDS dose 8 hourly.
Okay. Can you only give subcutaneously or any other route is possible?
Ma'am, IV infusion is also possible.
So if you are very refractory, you can use IV infusions, and even much higher doses can be given and titrated, then you come down. During this, what was your mode of feeding to this child? When you were titrating the child for control of hypoglycemia, what was your GIR and what was the mode of feeding?
My mode of feeding was that is RT feeding we are giving, IG feeding, and GIR we have to
How much?
increase up
Because
to
you were
18
very
mg per
slow
kg
in
per day.
progressing, so most of it yours would have been an IV fluid. But IG, how much was going on? Day 4, day 5, day 6? When did you reach
Ma'am,
full 100 ml per kg or 150 ml per kg of enteral feeds in this baby? On which day of life?
Ma'am, we haven't reached yet. The today is day of life 13, but around the there is a on day of life 10, we have raised 50% of the feed.
Okay.
And then now today is the baby on 70 ml per kg per day feed. But we haven't reached up to 100% of the enteral feeds yet.
Okay. And now, what is the therapy being? Your hypoglycemia is controlled with diazoxide, without diazoxide?
With diazoxide.
Okay. 12 milligram per kg per day you are giving. You could procure diazoxide was good. Where did you get it from?
We have to increase. Pardon, ma'am?
डाइजॉक्साइड कहाँ से मिला आपको? बहुत इजीली नहीं मिलता है इसलिए पूछा.
हाँ, नहीं मिला, इसलिए हमें octreotide हमको देना पड़ा था. यहाँ पे in Karamsad we have the Iris Hospital. From that we had talked with the Dr. Riddhi ma'am, pediatric endocrinologist.
Yeah. From Indore and from Mumbai also it was available. But one had to get it from various other places. So currently 18 milligram per kg per day of your patient is receiving diazoxide.
Currently, ma'am, we have omitted, and there is a maintaining the sugar also. RBS is also maintaining.
Okay, and your GIR is down to 6 milligram per kg per minute.
Yes, ma'am.
Okay. So finally, what would you like to put your this day 13 diagnosis for this child, and what is your further plan?
A single 13-day-old female born to primary mother, delivered with LSCS delivery with a very preterm 29.6 speaker, extremely low birth weight with 950 gram, appropriate with gestation age, with perinatal asphyxia, with respiratory distress syndrome, with needed mechanical ventilation, with surfactant therapy, with apnea, with coagulopathy, with resistant hypoglycemia. That is resolved now with tolerating feeding and baby on room air.
Current weight on day 13?
Current weight 870 gram.
Okay. So how much is the deficit? I think Dr. Sachin can come over. I think he had to somewhere.
Ma'am, there is a aware depth. There is a 20% weight loss.
Yeah, little less than 10%, around 10% weight loss. Okay. What are your other supporting? You did neonatal neurological examination, you did other examinations. So what would you call this baby now? A growing prem? Like looking at, it's a corrected 30, almost 32 weeker.
Yes.
Isn't it?
Yes, ma'am.
Corrected how many weeks of gestation now?
Ma'am, 29.6 weeker, and today is the 13th.
Almost 2 weeks done, so 31.5.
5, yes,
31.5 weeker corrected. What else in your 31.5 weeker? Now it's 2 weeks postnatal. What is there in pipeline for you now? How do you monitor further?
Ma'am, we monitor the head circumference twice weekly.
Okay. So what was your in this first 2 weeks finding in head circumference?
Yes, ma'am. There is a 0.5 centimeter increment in the last 2 weeks from birth.
How much increase? How much?
0.5 centimeter.
Okay.
0.5 centimeter.
Okay. Is it normal?
Yes, ma'am.
Normally a preterm, I agree, in first 2 weeks it doesn't grow. But now once the child starts growing, what is the increase in head circumference that you will expect?
Ma'am, 0.75 centimeter in 3rd week, in 1 centimeter in 4th week.
Sure. Why in 4th week it should be 1 centimeter?
Ma'am, this is written in Nelson.
Okay. And if you put it on chart, what has happened to you? Where are your on percentile charts? Where are your parameters?
Yeah, this one is ma'am. This is the birth chart
plotted on Fenton. So was your baby IUGR on Fenton's chart?
No, ma'am.
Where was the child? Child definitely even head growth wise was not.
That is a weight is 950 gram, head length is 35 and head circumference is 25 centimeter. So, and this the ponder index is more than 2.
So for an Indian mother and the growth chart on this, probably when will we call it as SFD?
Small for gestation. If the weight is less than 10 sometime.
Yeah.
And it will be the.
And even when we would look at all the parameters, whether persistent, all the parameters are less than 10 centile, or it's only on the weight, which can sometimes when the weight reduction, weight increase is not occurring, you may find that the weight is less than 10, while length and head are higher than 10 centile. Okay. What were your USG findings? This being a preterm, asphyxiated as per your assessment. What did you look at? 24 hours, 48 hours, day 7 and day 14 USG.
Maybe all done USG we had done, but the all findings are normal. Maybe had hypoglycemia, but there is no neurological.
Which is the area in brain which gets most predominantly affected if there is hypoglycemia?
White matter degeneration.
Which part of the brain?
In the white matter, there is the ventricles.
What would happen in ventricles in white?
No, ma'am. Brain parenchyma will be affected. There is white matter degenerations.
Sure.
Yes, ma'am.
So white matter degeneration would present as what? Because we are worried. That's why we monitor hypoglycemia.
Yes, ma'am. There is in the hypoglycemia, where there is a breathing difficulty affected, there is a motor, visual and sensory, and the white matter losses that will be.
Total occipital lobe is the most commonly affected.
Yes,
so V1 has to be looking at it. That's what it. But that cannot be seen on ultrasound.
Ultrasound. Yes. We need
So
to go
what
for MRI 4 to 6 weeks.
ultrasound in preterm we try to look for around 3rd week or 4th week. Yes, you didn't have any hemorrhage. That was a good sign. Your ventricle sizes are normal, are not increasing, is fine. But something ultrasound sometimes can give us a red flag.
Yes, there is a dilatation of the ventricles. There is a dilatation of the frontal horns. So, and
Which would occur in which condition?
hydrocephalus, then is a premat. So that will be the IVH. There is a preterm. There is a preterm. Then can we come to the post hemorrhagic
Yeah, so,
hydrocephalus?
but
That
there
is
was
a
no
complication.
IVH is what you are telling, that you didn't have even
Yes.
grade 1 IVH. So IVH is not there. What else you would want our sonologist to see, and you yourself also would try to look for?
PV
Excuse me,
or
ma'am.
periventricular leukomalacia changes we need to see.
So
Excuse me,
where
ma'am.
would it be seen and how would it look like?
Sheila ma'am.
There is cystic.
Time up. Yeah.
Yes, ma'am. I think we are half an hour overshooted. We have.
Okay, okay. We were just now
Yes.
going at. So
Yes.
probably you can just summarize quickly, Toral, for everybody in 5 or 2 minutes, so that everybody has a recap.
Just I'll say the diagnosis.
Yeah. So you had this 29 plus 6 weeker with maternal morbidity of severe PIH, emergency C-section for a poor Doppler study, probably by Apgar and asphyxiated baby. Those steroid fully covered, required surfactant, required around 24 to 36 hours of mechanical ventilation, no hemodynamic instability, responded to surfactant, and you could come to CPAP by 36 hours. Your major morbidity was little difficult to control hypoglycemia, probably not well documented as a glucose insulin ratio for hyperinsulinemia, but well controlled, and now the sugars are stable off all your hyperinsulinemic drugs. I mean, drugs which control hyperinsulinemia. And currently a stable baby whom you are waiting for it to grow, reaching full enteral feeds. You did not have a duct opening up, your lungs were fine, you are not on any oxygen therapy. So if this mother now is a very precious baby, wants to ask you about prognosis, probably we do not have time, but some other time we can discuss how do we counsel this mother for the further course in our NICU and on follow-up. I think I'll have to stop here, otherwise it will keep going.
Thank you, ma'am.
Dr. Sachin can just put in some final comments.
Dr. Sachin has left due to an emergency, so he
Okay,
just
okay,
left.
fine.
Thank you, sir.
So-
Thank you, ma'am.
Yeah, thank you so much. On behalf of NIF Gujarat, we are thankful to Dr. Sheila Iyer ma'am and Dr. Sachin Shah sir. Can I request Rituparna to present a certificate of appreciation?
Yes, sir. Thank you, sir. It was really impactful discussion. Now I will be sharing the, yes, sir.
So on behalf of NIF Gujarat, we would like to present a certificate of appreciation to Dr. Toral Gandhi for presenting a
Yes, Toral,
case.
well done. Huh? It's a good effort, and this is the way you keep learning. So you have to furthermore go into details, do some reviews. Okay,
Yes, thank you, ma'am. Thank you so much, ma'am.
good.
And we are also thankful to our expert, Dr. Sheila Iyer ma'am. Just make slideshow. Yeah. Next slide. We are also thankful to Sheila Iyer ma'am for being an expert in neonatal Pathshala PG case presentation on 19th April. Next, please. And we are also thankful to Dr. Sachin Shah for being an expert. He has to leave early. I mean, as he was supposed to be there till 4:30. So thank you so much, Dr. Sachin Shah. And thank you so much to Dr. Reshma Pujara and Dr. Dipen Patel for mentoring Toral Gandhi. Thank you. We'll be meeting next Wednesday at same time with Focus Series 4 lecture. So see you on next Wednesday. Thank you.
Thank you.
Thank you, ma'am. Thank you, ma'am. Thank you, sir.
Bye bye everyone.
We can end the meeting.
Thank you.
now.
Thank you.
Thank you everyone for your impactful discussion. Before we sign off, finally, I would request you to please visit our website for more updates, scientific updates. And I hope till we are meeting soon with the next topic on our platform. Until then, everybody stay healthy, stay safe. Have a nice day. Thank you all.
Thank you.
Thank you, ma'am.
Thank you.